Going to see me in a bit. I have a bit of a leg injury, so I'm going to take my mask off just for the presentation. Thanks for the very kind introduction, Dr. Schwartz, and really appreciate the chance to present our work today. This is some work that was a long time coming. We, as Dr. Schwartz said, a lot of us had various advisory roles over the pandemic. It's really hard to know when you're in the crucible of being in a certain country, travel restrictions, what happened here and how did we do compared to other countries and what can we learn from other countries. And so part of the impetus for doing this was really to start to get at that question. But then it does lead to some questions going forward, I think, as well, which is where I think a lot of the interesting discussion can be, which is, so we have this experience, what can we learn as clearly the pandemic is not over? As we go into year 3 of the pandemic, what can we do the same, differently? What are the lessons? So this is a paper that we published recently that's kind of a summary of this topic, which has a lot more details. Seha Shin was an amazing student of ours who's now a medical student who's a Dell graduate and is worked with us on our research team for about 5 years and is now at Western for medical school. David Naylor, I think all of you know, our former president of the university, and who wrote the first report on SARS-1, so importantly brings perspective on this. And Art Slutsky is one of the core members of the science table, the intensivist, and brought a lot of perspective in terms of possible capacity, critical care. So starting with the question of how did Canada do in the pandemic, I'm actually going to turn on a timer for myself here too. How did Canada do in the pandemic relative to other countries? So first is the question of what is a reasonable comparator? That is not straightforward. How do I do that?
Maybe able to. I don't know, Sonia, maybe something you need to do to show the transcription.
Sorry, can you say it again? What's wrong?
Can you show the transcription on the screen? It may not be possible. If Sonia can do it, she'll do it.
I can see the transcription. It should be there.
Yeah, but you know what? I think it's only going to be in the main screen of the Zoom. Yeah, but we're not.
I can show it. Yeah. Where are the options?
Because we're not in Zoom right now.
Okay. Oh, not in Zoom. Okay.
The Zoom is just for the recording. Okay. Sorry about that. Yeah, just confused.
Hey, you'll have to show me how to do that another time. Actually, I'd love to know how to do that. So, okay, so choosing comparator countries, actually not the most straightforward thing. A lot of countries did very poorly in the pandemic. A lot did very well. How do you choose a reasonable set of comparators for Canada? So that was the first challenge that we faced. And we tried to set some criteria ahead of time. We said, we want to get a grouping of countries. We ideally want to get a grouping of countries that existed before the pandemic started. And once we select a grouping of countries, we do not want to cherry pick. We're not going to add additional countries in. We're not going to take out countries. So we're not going to bias towards Canada looking good or Canada looking poorly. So pick a pre-existing grouping of countries. Okay, so what should be the criteria of those countries? They should have probably similar economic and political models. Think about the pandemic restrictions. When you say that we're going to shut schools down, or when you say we're going to reduce capacity in public places, or we're going to restrict movement, that's a pretty severe step, right? And you could do that potentially more easily in countries that don't have democratic laws, like you're seeing in China right now, versus a country like here, where there are certain norms and expectations on what you can do. So the political and economic model matters a lot when you're comparing countries. They should have similar per capita income level and the health system capacity. So this is important when you think about all the steps we did in the public health sphere. So we provided vaccination, and then when people got sick, we had to screen, we had to care for them once they ended up in hospital. We had to look at things like ICU capacity, which depends a lot on your income level. We said avoid very small countries. So the logistics of managing a pandemic across a huge geographic territory is different than a very small geographic territory. So we thought that it was relatively unfair, for example, to compare Canada to Singapore, right? Not really the same challenge, or Iceland is another example. And then finally, choose the largest group of comparators possible. So once you have those criteria, look for groupings of countries, see the largest group possible that fits that criteria. The largest that we found, and we haven't had an alternate suggested since we published this, was the G10. So the G10 countries, these countries, a lot of them would kind of come up as natural comparators for Canada. It includes the United States, United Kingdom, Germany, Italy, France, etc. Includes Japan, importantly as well. But there are important countries that are not on here. I'll highlight a few of them later in the presentation. So what did we look at in terms of COVID-19 related burden? We looked at the amount of infections that occurred. Infections matter not only because some will develop severe disease, but also because of the potential effect on work and school absences, economic disruption, the risk of developing things like long COVID. We looked at COVID-related deaths. This is the most severe spectrum of disease. This also includes things like the long-term care sector, where we had uncontrolled spread early in the pandemic. It also tells you something about the ability of hospitals to provide care for those who are critically ill. We looked at excess deaths. So I'll talk about excess deaths a bit more in a second, but it's less prone to misclassification. I'm sure many of you have seen the debate around whether we should label people in hospital as having COVID-related illness or being admitted for an unrelated reason and being incidentally to be found to be positive for COVID. So with COVID or from COVID, this debate. Excess deaths doesn't care about that. It just looks at the total number of people who died. And it also includes other factors that may have spiraled out of control, like when you have lack of access to healthcare, did addictions rates go up? Did overdoses go up? Did cancer screening plummet? So it looks at total deaths, and that's why it's valuable. And then finally, vaccination percentage, which tells you something about our ability to procure vaccines, which was very hard initially, and the logistics of distribution and getting to hard to reach communities. Here's a little bit more about excess deaths. There's multiple ways to calculate excess deaths. Actually, some of the pivotal work for this has been done here at the University of Toronto by Terry Moriarty in a Royal Society report. A widely used model is that which is used by the World in Data database, which is developed by Karolinsky and Kobach. And basically what they said is look at the total number of people who died on average for the 5 years leading into the pandemic, so 2015 to 2019. Account for secular trends, so populations could age, other factors could happen. So run a regression on that first 5 years of mortality, 2015, 2019, to give you a predicted mortality level during each year of the pandemic. So 2015 to 2019 predicts how many people should die in Canada in 2020 and 2021. Then look at the difference. Actually look at how many people died. So how many people died, this is a graph from one of our science table reports led by Laura Rosella and one of our students here at IHPME whose name escapes me, I'm sorry about that. Orange would be the actual deaths. The blue here would be the predicted deaths on a weekly basis from 2015 to 2019. The difference would be excess mortality. There are other ways to do this estimate. That's one widely used way that we adopted. What about public health measures? So a lot of public health measures were put in place. One widely used index of the severity of these public health measures was called the Oxford Stringency Index. It's a 9-component index that looked at school and workplace and transport closures, cancellation of events, restrictions on public gatherings, stay-at-home requirements, the information campaigns, restrictions on internal movements, and international travel controls. We adopted that framework, which is widely used. There are other frameworks out there as well. And we examined the median stringency by country and number of days at the extreme. So how often did countries go very extreme in their restrictions above the 90th percentile? How often were countries very lax below the 10th percentile? Economic indicators, so none of the authors on this paper are economists. We got advice from Professor Krasinski, who's the prior director of the economics program here at U of T, about some easy to use broad indicators that could reflect the pandemic effects. We settled on 4: unemployment, which all of you know has impacts just beyond just the economy and have direct health impacts as well. Gross domestic product per capita, so some measure of economic productivity during the pandemic. Inflation rate, and then debt spending. So specifically debt spending relative to GDP. So what were some of the results? So starting with infections and vaccination, on the left, panel A gives you infections. And again, this is over the first 2 years. This doesn't include the Omicron wave, which is yet to complete. Over the first 2 years, you can see a huge spread in infection rates. Japan was the lowest, so 27,000 infections per million. Canada was the next lowest, about 3 to 4 times higher at 80,000 infections per million. And then you see this huge spread, and you have countries like France, the Netherlands, Belgium, nearly 3 times higher in terms of infection rate. What about vaccination? So vaccination, again, you had a fair bit of spread. The lowest was the United States at about 65%. This is dose 2 vaccination rate, so it doesn't carry us forward to boosters. And Canada was actually the highest vaccination rate. And the other interesting thing about Canada is you can see as this turquoise line, it started very late. So if you remember, vaccine availability was a major issue here, and there was the lineups and it was hard to get vaccines. But what is truly remarkable is what happened once the vaccines became available. Again, a lot of pivotal work came out of the University of Toronto. So it was these campaigns that took out vaccines to the elderly and the infirm, went to their apartment buildings and went into low-income neighborhoods. A lot of strategies were used, and we had the highest vaccinated population in the G10. What about death rate? So again, a huge spread. This is panel C now. Japan, the lowest at 150 deaths per million. Canada, the next lowest, about 6 times higher at 919 deaths per million. And then again, a huge spread. And you see the United States sitting at the top with 3 times higher death rate than Canada. So 2,700 deaths per million in the first 2 years. If you look at the excess mortality, it tells a similar pattern. So Canada had about 450 excess deaths per million. Italy and the United States 5 times higher at about 2,500 excess deaths per million. So huge spread. Remember, excess deaths includes all deaths, not just COVID-related addictions, car accidents, cancer, everything. Public health measures. So on the left is a box plot. The dark black line is the median. The parameters of the box are the 25th to 70th percentile, and the whiskers are 1090. You can see that Canada had the second highest level of public health measures, public health restrictions over the pandemic. And you can see that it also had a very narrow range. So if you look at the 1090th percentile whiskers, you'll see it's relatively compact. Compare that, for example, to a country like Sweden, where you see these huge swings back and forth. And that's reflected on the plots on the right, where we had we had among the lower rates of days above the 90th percentile. So we actually didn't go that strict, 90th percentile, but we also had fewer days below the 10th percentile. So we kind of went high and stayed high over the course of the pandemic. And that's reflected by a heat map as well. So if you look at Italy, which again had the highest rate, Canada just behind, we generated a heat map for each week of the pandemic, and days above the 80th percentile are in red, days below the 20th percentile are in green. You can see that Canada, the second row from the top, went red, just like all other countries, pretty much all other countries, right at the start of the pandemic waves in early 2020. But notice we never went back. So we stayed red orange the entire time. So we maintained relatively high levels of restrictions. Unlike any other country, even Italy had periods where it went back towards the green during the pandemic. So we maintained relatively high levels. This is broken down by the 9 subcomponents of the Oxford Stringency Index. Canada scored relatively high on a number of these. I'll just quickly summarize that we were high on restricting internal movements, international travel restrictions, canceling public events, restricting public gatherings, school closures, and workplace closures. And if you look specifically at school closures, this is primary and secondary school closures from a UNESCO report. We were second highest in the G10 for primary and secondary school closures. So 51 weeks out of the first 2 years, which is really remarkable how much we closed our schools. What about economic measures? So unemployment rate, all countries essentially are back to baseline unemployment rates from prior to the pandemic. Canada was roughly middle of the pack in terms of change in unemployment rates. In terms of GDP per capita, we had the biggest contraction of our economy of any of the G10 countries, so about a 1.5% contraction during the pandemic. Change in inflation rate. Obviously, inflation's been a huge issue here in Canada, but it is a global issue. It's not a Canada-specific issue. And in fact, we are roughly middle of the pack in terms of our inflation rates. And then finally, debt spending. We were relatively high in terms of debt spending during the pandemic. A lot of the public programs that I think benefited a lot of people in the country. Importantly, at the end of that debt spending period, it left us roughly middle of the pack in total debt to GDP. What I'm showing you here is the change in debt spending over those 2 years. So to summarize how we did in that 2-year period, we had among the best performances in terms of COVID burden, only behind Japan, really. So those are the first 4 columns. We had the second lowest cumulative confirmed rate cases. We had the highest vaccination rate. We had the second lowest number of deaths, and we had the second lowest excess mortality. In terms of stringency, we were the second highest, so we experienced fairly strict restrictions that were persistent over the course of the pandemic. And then in terms of economic parameters, we were roughly middle of the pack in terms of economic parameters. So let's talk a bit about Japan. So it's obvious from this presentation that Canada did very well in terms of COVID burden, but Japan just did markedly better. Right, so it wasn't even close. For Japan was truly the outlier versus every other country. It is unclear why Japan is such an outlier compared to every other country, but we can say confidently that it's not because of vaccination rate. Remember, they're not the highest vaccinated population. It's not because of public health measures. If you look at public health measures, in fact, they were the lowest in terms of restrictions, okay, of any country. So it's not vaccination rates, it's not public health measures. Potential explanations, active area of study. One is isolation as an island. So obviously in the era of air travel, it's not magical to be an island. But it is notable that some of the countries that did really well during the pandemic are also islands, Taiwan, New Zealand, Australia. It is easier to restrict travel as an island than it is for any country that has a large land border. Our land border, for example, with the United States, we depend as a functional society on that land border working, right? Produce, automotive goods, whatever it is, our economy can't function if that land border is shut down. Island nations have gotten to a set economic model where they can have strictly isolations towards the products that are brought in as part of their economy, things that are brought in by freight ships, for example, versus all other kinds of travel. It's harder to do that in the European Union or in the United States or in Canada. Baseline population immunity from previous coronavirus infections. So this is an interesting observation, which is that, of course, there's been coronavirus for SARS-CoV-2, SARS-CoV-1 we know of course, but there's other coronaviruses. There seems to be higher levels of exposure in Japan from prior coronavirus infections. Could have given them some baseline level of immunity that protected them as SARS-CoV-2 came through. Highly prevalent genetic differences. So Japan's a fairly homogeneous society, and there seems to be a higher stable difference in a certain kind of haplotype leukocyte antigen in the population relative to other populations. There's a lot of immunology research by Japanese researchers looking at their population, and they seem to have less severe reactions to respiratory infections. So I'm not an immunologist, but an interesting emerging theory. Cultural differences in mask compliance. This is probably a major effect. So if you think about the debates that are happening here around masks, you look at even in a public health setting, you have a spread and a split in the room, right? And who's wearing a mask. It is much more normal in many East Asian societies to wear masks. It was done before COVID. It's done routinely during respiratory virus season. And when that recommendation was made in Japan, along with early recognition by their public health officials that this was an aerosolized virus, that is still surprisingly debated by some people today whether the virus is aerosolized. There was a fast implementation of masks. So even though all the public health measures in an aggregate didn't look as strict as other countries, there was early use of masking in Japan and persistent use of masking. What about Canada? So among the remaining countries, and some will argue that Canada is more comparable to the other countries. I don't want to exclude Japan and say it's different. There are some differences that are interesting, but Canada has a lot more similarities to some of these other countries. I will keep going unless it shuts down. Okay.
Have a battery here.
Waiting for the voice of God from the rafters again. Okay.
It is cute.
Okay.
Well, yeah.
All right.
Look, this isn't working. Carry on.
Okay, so among the remaining countries, Canada had the lowest COVID-19 burden. It had the highest dose one, dose 2 vaccination rate of any country in the G10. Our public did experience some of the strictest restrictions in terms of these public health measures, and they were persistent. Most countries are now at a pre-pandemic employment level. Inflation has risen clearly. Government debt rose for all countries. Canada's about middle of it. So that would be the summary for Canada. What is the impact? So if you look at Canada versus the other G10 countries, and if you look at the countries that did the worst on each of these indicators, if you looked at the country with the highest mortality, it was the United States. If we on a per capita basis had the same mortality rate as the United States, we would have had 70,000 more Canadians die in the first 2 years. That is an enormous number for a country our size, right? That means most of us would probably know an elderly family member, someone who's immunocompromised who would have died, who's alive today if we had followed the US course, would have died. The second is vaccination rates. So again, the US was the lowest. We had 6 million more vaccinations here in Canada over the first 2 years for our population size versus the United States. Again, an enormous number for a country of 40 million people. And we had 9 million fewer infections than France. Again, an enormous number, but roughly 25% of the population. That matters. Remember the disruptions that occurs when those infections happen. Obviously, some people could have gotten very sick. There's still risk for things like long COVID that we have to care about. So those differences are enormous. But there are countries that are not in the G10 that we shouldn't ignore when we make this kind of comparison. Countries that are notably commented on that I've not included in this analysis include countries like Australia, Taiwan, New Zealand, and you can see they cluster with Japan. So before we say Japan is a different society, we should look at countries that probably we would consider to be more of the Canadian model, American model, European model of a country, which is countries like Australia and New Zealand, which also had much lower rates of disease. This is deaths per million. Notably, all 4 on the bottom are islands as well. Okay, so Japan is intriguing. So thinking more about Japan, what can explain what happened in Japan? What about the role of trust? So this is an interesting paper that was published in the Lancet earlier this year that looked at, it's starting to look at ecologic analysis around what could explain the pandemic differences in countries. As authors, we avoided intentionally, despite pushback, doing an ecologic analysis because ecologic analysis, I know this from personal experience, having been skewered for some of them, are highly fraught. And the pandemic is not over, and the waves are coming at different stages in different parts in different countries. Vaccination rates are different, immune status is different. Right now, I think in many ways is not the right time to start to pour into ecologic analysis. You have to be very careful. But this was published, and I think there's some interesting findings in it. So this was an exploratory analysis of correlates of COVID-19 prevention and treatment across 177 countries. They considered a wide range of factors, things like infection rates, altitude, age profile, seasonality. Age profile, I should mention, Japan has the oldest population on average, so again, should have had higher rates of severe disease. Pandemic preparedness indices, like the indices prepared by the Johns Hopkins Center, health system capacity indicators like hospital capacity, ICU capacity, governance variables, measures of economic inequality, and trust. So they had survey data on these countries that measured trust as well. And what they found is quite interesting. So in terms of the number of infections per capita explained by each factor, that's the first column, trust became one of the most important variables. These are questions around, do you trust other people in society? Do you trust your government? And they explained roughly 7.5% and 16.5% of the total variance. And then when they looked at what would happen if countries could get up to the level of trust of a country that's at the 75th percentile, that's Denmark, they found that it could probably explain about 13% of the difference in terms of infection rates if you look at trust in government, and up to 40% seems a very large number of the infection differences if you look at interpersonal trust. And that's what this is, the summary that say what could happen if you hit that level of Denmark's level of trust. Okay, so this is some work by an IHPME professor, Neil Seaman, who I've had the pleasure of working with, who's the chair of a data organization called RIWI. And they just completed, just in the last couple of months, a survey of trust and how divisive countries feel, people in countries feel that the political system is across most of the countries that we analyzed. And they found a large spread in trust. So the question here is, to what extent are people in your country politically divided? So extremely or extremely or very divided. In the United States, more than 50% think that the population, the country is extremely or very divided. It goes down. Canada is only a third of our population, but look at Japan, again, an outlier. So only 20% of the population think that it's extremely divided, right? That's a big difference. And if you connect that to the Lancet study, how much could it explain? We wrote about this actually just 2 days ago. Neil and I wrote about it in the Toronto Star. And one of the things that we wondered is a highly trusting society like Japan innately more able to see changes, and there were so many changes over the course of the pandemic, masking, the right vaccine, think about all the changes that we told people about it. Is a trusting society more likely to not see this as errors, or worse, like in the United States, and to some extent here, conspiracies, but are they more likely to integrate it as just evolving science and an opportunity to learn from error and embrace its teachings? So is that possible? Is it possible that trust explains the way that people respond to changes? And there's been so many changes over the course of the pandemic. And maybe that explains partially some of the warning signs we're seeing in Canada. So dose 1, dose 2 of the vaccine, as I mentioned, we were the highest in the G10. This is now booster doses. And you can see we are no longer anywhere close to the highest. In fact, who is the highest? Japan. We are firmly now middle of the pack in terms of our booster doses. And all of you know this, I think, if you talk to friends and family and those around you, the engagement and belief in vaccines has diminished here notably. And how much of that is lack of trust about the fact that the changes are not because of evolving science, but because there are other things that people hear about. They see the story on right-wing media, or they see other things that tell them there are other reasons why the story is changing, not just evolving science. So where do we go from here? This is an op-ed that I wrote with Art and David earlier this summer. And it starts by acknowledging that we did do better than most of our peers in the first 2 years of the pandemic. Who deserves credit for that? So we had the highest 2-dose vaccination rate in the G10. We had these really stringent public health measures. But if you think about it, of course, government deserves credit for doing that. But who actually went out and got vaccinated? It is the public, right? They went out and got vaccinated. They believed us in public health when we said to go out and get vaccinated. And who suffers from public health restrictions? The public. So in many ways, the unsung heroes of the last 2 years, I think there was good policy, but the unsung heroes are the public that went out and got vaccinated. They proved that if you gave them the right information here in Canada, they would go out and get vaccinated. So the same people who are not getting the boosters today got their dose 1, dose 2 in the last 2 years. So it's really about messaging. And they went through these public health restrictions. And here are some of the other areas that we discussed that we think are important now. So first is monitoring and surveillance. In order to know what variants are circulating, we still largely rely on PCR testing. There is some evolving science around using wastewater to do this, but we still rely on PCR testing. We have, since January of this year, we have among the lowest rates of PCR testing in Canada of any country in the G10, second most in the G10. So that's a major source of concern. The second is wastewater. So the science table we had under Peter Uni's leadership and collaboration across the province, we put up wastewater signal data that became really useful in understanding the pandemic trajectory. That wastewater data that we presented is no longer available. So as of the science table dissolving, it's no longer available. Now, there is a promise from government that that will become available, remains to be seen, but that data is really, really useful. And sometimes it can give you a message which is not convenient for policymakers. It can tell you that even though you want to move past the pandemic, that in fact, there's a large amount of viral spread happening, and you can't get that information from many other places anymore. Completeness of data and reducing data lags. So it's really important to know that even though many people are trying to push past the pandemic, it's still affecting certain sectors of society in a very significant way. And we don't necessarily have the right data to see that in real time and to mitigate it. This was an important analysis done by Sharmista Mishra, who's an IHPME professor and an infectious disease doctor. She did this actually on request from the Toronto Star. There was already evidence from the United States. The Washington Post and New York Times had done an analysis to show that even though there was this story being told that Omicron was less severe, because it's highly infectious, a less severe variant that infects many more people actually ends up causing more sickness. And so Sharmista looked in Ontario at rates of disease and death from Omicron compared to the prior 2 waves, so since vaccines have become available. And what she showed importantly is that more people over the age of 60 died in the last 6 months, so from January to June, than at any point in the pandemic since vaccines became available. So even though we had a highly vaccinated population, and even though Omicron was less severe, it was so infectious that more people died in that 6-month stretch. And in fact, more people died than in the previous 2 waves combined over the age of 60. So that really tells a very different story than we're through the pandemic. And you can see this latest blip here, that's before BA5, which also generated another. Second issue, maintaining public trust through smart policy. So when we've presented the results of this analysis, a lot of people are surprised. They didn't know how well Canada did. They know things were tough here. They know we have a lot of inflation. And they didn't know how well we did. And part of rallying a population, we think, about going through this next phase, it's no longer people banging on pots on their windows to celebrate healthcare workers. It's a lot less positive and a lot more divisive now. How do you tell a story about how well we did, but acknowledge that we're still not through this and we need to learn from that success going forward? I don't think enough has been said about that. Precision public health measures. So we had among the strictest restrictions. All of those restrictions were put in place, I believe, with good intention. They are clearly not evidence-based at this point. So let's talk about travel restrictions. So when the Omicron variant emerged, it was first identified in South Africa. Many governments, including our own, put on immediate, fairly strict travel restrictions from anyone from Southern Africa, not just South Africa, but any neighboring country, with the fairly naive claim that it was going to limit the spread or slow the spread of that variant out to other places. I think all of you would acknowledge in a globalized world that we live in with air traffic and other things, that is impossible for that actually to occur. And lo and behold, months later, analysis retrospectively of data from Scandinavian countries showed that the Omicron variant was present there well before South Africa announced it. So South Africa has good monitoring for variants. They did the work. They honestly went forward and said, we found this variant, and they got punished for it. And they got punished, whereas other countries that had the variant clearly circulating already said nothing, and air travel and economic impacts were minimized for those countries. So clearly that is not both fair and rational decision making. And we probably need to look at things like that as we go forward and say, how many of these measures can we really pull down to maintain pandemic control while still allowing the rest of life to get as close to normal as possible? Probably one of those things is masking, right? So masking, vaccinations, and improving air quality are probably the core things we need to rally around, and we need to pull away from some of the more divisive things like the travel restrictions. Mentioned passive risk reduction. So all of you know from public health and from behavioral sciences that anything that can be done passively is more effective in many ways than things that require active engagement. When you improve air quality indoors, U of T and other places have invested heavily in your air quality. You don't rely on each individual becoming vaccinated or mask wearing. You have this passive protection that can be very important. And then transparency. So many of us, myself, absolutely myself included, went out and told people early in the pandemic, just get your vaccines, we'll get through this. Clearly, that was way optimistic for what has happened, right? And people lose trust. They lose trust when you make those promises. I don't think, again, that any of us made those promises believing that, in fact, we weren't going to get through this with just 2 doses. We believed it at the time. But there is a lesson from that we have to be much more cautious in the way we message these things, because there has been a loss of trust because of some of the early optimistic claims that were made by us. So I'll wrap up by saying, talking a bit about what has us worried. This was an op-ed that we just wrote a couple of weeks ago. Catherine Smart was the president of the Canadian Medical Association at the time we wrote this. Alika LaFontaine is the incoming president and now current president of the Canadian Medical Association, and Art and David I already introduced. And this was really driven by the observation that in August, we had never seen hospitals widely across the country have closures the way that we experienced just in the last month. So August is traditionally a recovery period for acute care in hospitals. It's like everyone else, people go to cottages, people recover, and they get ready for that big surge that happens late in the fall, early winter with influenza. We have a system now which has been essentially forced to surge every 3 to 6 months for 2.5 years. It is severely constrained. It is very short-staffed. I've never seen it as short-staffed as it is right now. I'm at one of the hospitals that is the 2 trauma centers for the city. And at periods over the summer, we lost our ability to do MRIs overnight because of staffing. It's crazy. We've never seen anything like that. You've had, there's a report today that over 80 emergency room closures in the province over the summer have occurred. That has never happened, and we're just entering influenza and potentially a season of another COVID wave. We've seen COVID waves occur every roughly 3 to 6 months. So this system enters the fall and winter. Things could be very, very difficult here. And, you know, we said we love Game of Thrones, so we said winter is coming. Without clarity and candor on the part of leaders, and without some low burden and urgent measures to mitigate the spread of the multiple viruses in the near future, Canadians face the real prospect of more disruptions to their healthcare services and long-term damage from continued exodus of demoralized healthcare workers. I can say personally, I had a physician that I trained under who was our division director, who is someone in the prime of their career in their early 50s, just walked away. Said, I don't know, like, I'm not doing this anymore, has left medicine. I've never seen that in my career, seen someone walk away like that. I'll stop there.